when you're really down to no cash flow, you're worried about whether your car is going to break and you'll be able to get to your job. You know, whether a large appliance is going to break and you're, you know, or, you know, who's going to take care of the child, or gosh, if somebody gets sick, what do I need to do? The last thing sometimes a low-income person needs is to pay money for a big corporate health insurance policy, which is what we have under Obamacare. So that's one way they continually sold Medicaid. You're a low-income person, we need to cover low-income people with Medicaid so that they can work. The problem is that for a single person, under 133% of poverty level, which is the current Medicaid coverage in Colorado, that's basically, if you are making minimum wage and working 40 hours a week, you're not eligible for Medicaid, a single person. So, do you need insurance at that point? Because what happens if you get so sick you can't work? You stop earning that kind of money, and then what happens? You're instantly eligible for Medicaid. So why would you buy a health insurance plan? Why should you be forced to buy a health insurance plan? That just makes it harder for you to get ahead. So that's the thing to think about the next time somebody says, well, we need to, you know, force low-income people to buy a health insurance plan because, gee, there's all this uncompensated care. Well, my response to that is, if hospitals are incurring uncompensated care, then pay the hospitals for the uncompensated care out of general tax revenues. But you've got to accept the fact that if you're going to have something like Medicaid, they're going to pay people who are rationally uninsured. And it's probably going to cost more, probably. We know from Obamacare that it's going to cost more to get them insurance than it is to simply let them be rationally uninsured. So that's the point here. And from all Medicaid expansion that's been done, there's no evidence that covering basically healthy people like children and able-bodied adults does anything to improve their health. The latest problem that the progressives have had to face is they did a randomized experiment in Oregon, and they found that if you cover people with Medicaid, utilization rates go up by 30% with no discernible effects on health. They found that with the Rand Health Insurance experiment, which took place in the 1970s, utilization rates go up by 30%, no discernible effects on health. Okay. You know, if I have a sore throat and I get to go to the doctor for $2 or $0, I'm going to go and find out. It's a lot easier than not. So this is what Colorado Medicaid growth has looked like for enrollment. A couple of things to notice. The trend changed dramatically in 2008. What happened in 2008? Okay, fairly political group. Everybody knows what happened in this state in 2008. Democrats controlled all parts of the state government. They immediately started expanding Medicaid. The purple part is Obamacare. One of the things that's happened with Obamacare is the forecasts have been way off about the number of people enrolled in Medicaid. Now this has some problems. When you get into Medicaid, well, first of all, the black line, that's Colorado's population growth. Right? So it's either this population is getting much, much sicker, or worse, or there were all kinds of people dying in the street before that are not dying anymore. Has anybody noticed that? Or we are just covering a lot of fairly healthy people on Medicaid. Because remember, before the expansion, if you were disabled or you were chronically ill, you had a route into Medicaid because of your illness. So there just weren't, there was, people on the edge who needed, high blood pressure meds, but there weren't a lot of people floating around who were seriously ill who couldn't get care. And Colorado has something called the Colorado Indigent Care Program, which existed to help people who were, I am a low-income worker, and all of a sudden I need my gallbladder removed. It worked to help people get low-priced care in that instance. And in some cases, it's much more focused than Medicaid, so it's a better deal for the taxpayer. The next thing is who is part of this enrollment. Mostly healthy children. Those are the green ones. Kids are cheap. The stripes are the adults that have been the able-bodied adults that have been in Obamacare. And then you've got the little blue and the little thing that are the elderly nursing homes, the disabled people, the developmentally disabled, people who really can't work, need a lot of help. The problem with this, and this is what happens, going to happen with the plan, too, the plan, the Initiative 20. is that when you start looking at numbers, people who run these programs can't help it. They look at the percentage of the people who are generating costs, which are the little 2 blue bits down there, because these people are seriously ill and they need care. And they say things like, oh my gosh, 10% of the people are generating 80% of the costs. We have to do something about those costly people. And so they start chopping spending on the disabled and the sick people who really need it. But heck, all of those green people and the striped people, they vote, their family members, we really respond to this large group. We've got to make sure that they get their fair share. So what happens is you end up stinting, it's called, on care for people who are seriously ill and providing too much spending on the healthy. Get all the counseling programs. Do we really need another anti-smoking program? Really? Yeah. So the plan, Initiative 20, will do this only worse, because every time you have government control of something, it responds to the political group, which is mostly healthy voters who don't need a lot of care. Young people are especially bad this way. They look at me, I'm like, I'm old, I need health care. Oh, just, get a better diet. No, it's not going to help, if I have cancer. Really, trust me, it's not going to help. So what happens in things like this plan, the Initiative 20, is that people who really need a lot spent on them get their care stinted on. They don't have access to new drugs, they don't have access to surgery, they sit on waiting lists, and they die at much higher rates. Next one is, again, looking at spending. You can see here's the spending. The blue takes up the most spending, the really sick people, but the kids and the adults not so much. Well, what about total appropriations for this? We were told that this was going to be pretty much free. So this is a good guide to, recognizing misstatements when they're made to you. Remember, because Obamacare was going to cover 90% of the costs of any new enrollees under Obamacare. But in fact, the state has been using the healthcare provider fee, which is actually a tax in the letter that authorized it, go figure, to expand Medicaid on its own. And that's the main reason they need to take it into an enterprise fund, because it would give them tax room under table for another $1 billion, which they're going to need to fund this Medicaid expansion. And the reason they're going to need it is right now, this is, I should say one more thing, sorry. You can see this is a 10-year split from, whatever it is, $6.3 billion in 2005. That's the state spending. The second circle should really be 2/3 or a third bigger than the first circle. Total state spending has gone up quite a bit. And you can see that Medicaid is starting to eat the budget like Pac-Man. And to be fair to legislators, it's much more fun to be in office when you can spend other people's money on doing good things for people. It's really not fun at all to be in office when you're having to cut the budget because Medicaid's on autopilot and you're having to take away funding from schools, from roads, from everything else, because that makes a whole lot of people really angry at you. So the political incentive here is to somehow make room in the budget so you can spend more money. So you do that by moving the hospital provider fee off budget and having more table room so that they can tax us for another $1 billion or so. So that's sort of what's going on. So if you have Initiative 20, basically what that does is it takes all of the health spending in the state out from under any table limit. Lets them have, it says in the initiative, they're going to have a vote to raise taxes once a year. There's no limit. Any resident can vote to raise those taxes. There's no citizenship requirement. There's no requirement about when you have to hold the election. I'm expecting, 12:01 a.m. on January 1st. And the people covered by the plan have to be residents of Colorado for a year. Now you tell me how you show, or whether the plan will even check whether you've been resident in Colorado for a year, because they're not even doing a very good job of checking Medicaid income. Or they're not checking Obamacare income at all. It's all self-attestation right now, because they never got the software built to check. So again, the on steroids remark about Initiative 20 is, if you're a resident of Colorado, free healthcare, go for it. So this is showing the Pac-Man effect of the budget. It's getting bigger and bigger. It's going to get even bigger because this is who the State Department of Healthcare Policy and Financing works for. look at the incentives here. 60% of its budget comes from federal funds. When the federal government says jump, what do you think they're going to do? They're going to say how high. And so we have in Colorado been getting pretty much every federal experiment on Medicaid there is coming down the pike, and the system is continuously in turmoil. They're right now, for a while they changed mental health care. It used to be gotten in primary care, then they took it to these specialized mental health centers. Now they're moving it back into primary care. Okay? They're forcing everybody into accountable care organizations, which are untested entities, which probably don't seem to be working so far and probably won't work for a variety of reasons. But hey, poor people, well, or not very poor people anymore, we can test them, not a problem. Well, here's what happened. We have one case of a state which expanded Medicaid and then contracted it, and that state is Tennessee. Tennessee in 1992 drank the Robert Wood Johnson Foundation Kool-Aid and the governor said, use us as a test case for what would eventually become Obamacare. Anybody who doesn't have health insurance in our state, we'll enroll them in Medicaid. So, by 2002, the state budget was in a catastrophic state. They were looking like they were going to go bankrupt. It got so bad that in 2003, 4, and 5, the new governor by then, absolutely stepped up and said, we've got to reduce our Medicaid program. It's the only case where it's actually been reduced in recent history. And here's what happened to hospital admissions. Brand new paper just came out a couple of months ago, which gives you an idea of why government shouldn't control anything anyway. Here you have a major program, huge spending, and studies on it come out 10 years later, and they were done by academics. Government can't keep track of what it's doing either, and neither will the plan be able to. But I want you to look at the red numbers. Look at these are hospital admissions per 1,000 people. Now, what we hear from Medicaid is that they control spending and they have good utilization because it's totally government controlled and they have all these requirements, etc. I don't know what they were doing in the hospitals in Tennessee, but they were admitting a heck of a lot of people. So in the 4 years before they cut Medicaid, it was 5.6 per 1,000 people. In the 4 years after, it was 2.5 per 1,000 people. Now, as you expect, a lot of people were uninsured. They got dumped off Medicaid and they said, heck no, I'm not going to buy insurance. I don't need it. I know I can go back on it, etc. So the uninsured hospital admissions went up. And this is what you always hear from the hospitals. Medicaid is really our uncompensated care center. Medicaid is the largest generator of uncompensated care in the country because it pays about 50%. Medicare is now generating uncompensated care as well because it's a little bit below cost, and Obamacare is going to cut it even further. So if you're on Medicare, it's been okay up till now because it was benchmarked by the private sector. Now, it's going to get probably considerably worse over the next 10 years. So in any case, when hospitals start talking about the number of insured cutting Medicaid generates, take a look and ask whether the number of hospital admissions that it was reduced by, possibly are bigger savings than the amount of uncompensated care the state would have to pay for. And I think that you're probably better off reducing Medicaid and then paying for the uncompensated care another way. But I don't know what was going on in Tennessee. Everybody in Tennessee looks like they're in the hospital. I mean, these southern states were sort of neighboring states. What are you doing? But imagine what it's going to look like in the plan where you don't even have individuals with any skin in the game at all. So here's bottom line on what happened to Colorado Medicaid after Obamacare. And the thing to remember is they said it was going to be free because it was going to be matched. Well, the problem is that there were a lot of people who were eligible for Medicaid but not enrolled prior to Obamacare. They made up about 1/3 of the uninsured population. And when you start pressing these people into enroll and you do outreach and everything, they enrolled. And that's what the 7.9% increase from fiscal year 14-15 to fiscal year 15-16 is. The dirty little secret for the state budget is those people the state has to pay 50% for. So Medicaid enrollment has gone up, both for the part that the state has to pay for, and for the second part, which is the part that Obamacare is going to to start matched at 100% to lure the states in, and is now going to cut the reimbursement to 90%. And the state also, as somebody mentioned, has to pay the administrative part. So bureaucracy is exploding. If you think this is interesting, imagine what's going to happen when any resident of healthcare of Colorado has a claim on healthcare in Colorado. It's going to be really interesting under the plan. So, what would I do instead? This is the Medicaid growth is absolutely unsustainable. It doesn't lead to good usage of medical resources. It tends to a lot of overuse. When anybody talks about emergency department overuse, it's almost always Medicaid patients. And the reason is you have a $3 to $5 copay. Why wouldn't you go to the emergency room? It's perfectly rational. It's open 24/7. All the tests are in one place. They get it done really fast. Why not go there? But the federal government has resisted. The federal government, the copays are set in statute at $3. Nobody bothers to collect them. It costs more to collect them than it does to pay them. And the federal government has refused to even increase it for the rate of inflation. Okay? So that's how difficult and badly constructed the Medicaid program is. So what's not to like about our current healthcare system? If I'm proposing reforms, you've got to have the payer and the patient be the same person. Right? And that's what we do with food stamps. We give people a subsidized amount, and we say, go out into the market and purchase what you want within a broad limit, no alcohol in theory. And you decide what you want to buy, you decide the trade-offs, you decide what kind of food you like. But we didn't try to nationalize agriculture. Right? But in healthcare, we've nationalized agriculture. And we have expert planners telling everybody what they should consume. And it doesn't work because people are all different. They want different things. And so the first thing, and when we do that, when we get people and their payment together, we save a bunch of money. The consumer-directed health plans with the high deductibles, I have one. I'm one of these people that goes and asks for cash on every single visit because sometimes it's cheaper to pay cash. Often it's cheaper to pay cash. And plus it gives me out of the all-payer claims database too, which is even better. But the payer, even in Medicaid, there's a program in Colorado called Consumer-Directed Attendance Support. And when you're a Medicaid person who's disabled, you go in and you get a care plan where the state says, with your disabilities, we'll give you this much for home care over the year, this many hours of home care at this rate. Now you have a choice. You can either have the Medicaid department send people to your home for home care, or we'll give you a budget. You subtract 3% from that budget for administrative services, and then you hire your own health care people and you pay them what you wish. People love CDAS, and they say estimates are anywhere from 10 to 20%. They can get care for less. They're much healthier, they're much happier, they get better care. They don't have people stealing their stuff who get sent in by an agency that they don't know. The state hates CDAS and tries to get rid of it. But that's an example of why, if you put the payer and the patient at the same point, you're going to get better off. So most Medicare reforms are saying, let's give people a certain amount of cash, let them spend it. The consumer-directed health plans are saving about 5 to 7% on expenditures for big companies. You say that's not much. In healthcare, that's huge. So that's what we can do. Second is to remember that prices are a communication system between buyers and sellers. If somebody makes a ton of profit because they figured out how to open a new imaging center that is open 24/7 and is cheaper, then what does that signal to them? That stimulates people's brains. We should open more imaging centers, and you get more imaging centers that are more convenient. In Denver, they're doing, and here also, the first choice emergency rooms, the freestanding emergency rooms. Anybody ever used one here? Those are emergency rooms that aren't affiliated with the hospital. This bunch of doctors said, we can do emergency care better. And so they're locating them where hospitals aren't, in places that they feel are underserved. They charge the same, but they're making money, which suggests that our model of provision of emergency services probably isn't very good. And if these guys make a profit, they'll do more of them until the point where they don't make a profit anymore. So when people say that we shouldn't have any profit in medicine, I would argue they're dead wrong. We need to know what people want and what works, and the only way to find that out is through profits. Third thing, meaningful choice, and that's what you get when you want patients and payment together and you want to have profits or losses. Meaningful choice requires that you have viable alternatives to choose from, which means the government doesn't get to circumscribe the health plans that you can provide, you can buy, dump them into something called the Colorado Health Exchange and call it the insurance marketplace. There's no viable choices in there. All you get to choose is from some crummy plan that bureaucrats specified. You get to choose what percentage of it you're going to pay. That's not choice. It's not choice when they tell you what kind of treatment you have to have for a particular condition or the exact drug that you need to take, because you might have a reaction to it. The reason we have so many different kinds of drugs is we have so many different biologies in human beings. Third, healthcare, you never get more than you pay for. Lots of times you get less. Your government tries to tell you that you will get more than you pay for. It's not true. And finally, value is in the eye of the beholder. Okay, that's the patient. Some third party sitting out here telling you what you should value, doesn't know your travel time, doesn't know your work schedule, doesn't know that you have 4 screaming toddlers that you have to feed, and so you can't sit around a clinic all day waiting for an appointment. And that's why we're going to see big changes in the way doctors operate, and if government would get off everybody else's back, we'd see enormous changes in how hospitals, drug companies, and everybody else operates. So I'll leave you with one thing. From my perspective, government is the problem, not the solution. So thanks very much.